So welcome everyone to this keynote presentation. My name is Dr. Pamela Kent. I'm the Associate Director of Research at the Canadian Centre on Substance Use and Addiction. I'm joining you today from Ottawa, which is located on the traditional unceded territory of the Algonquin Anishinaabe people. I'm honored to be chairing this keynote presentation today. So this keynote will be followed by a 10-minute Q&A. So as with the other sessions, please enter any questions you have into the Q&A function on WOBA. So I'd like to start by introducing you to our keynote speaker, Dr. Michael P. Schaub. Dr. Schaub is an associate professor at the University of Zurich and the scientific director of the Swiss Research Institute of Public Health and Addiction, ISGF, a WHO collaborating center associated with the University of Zurich. He's a trained psychotherapist with a strong clinical and scientific background, as well as a public health expert in the area of substance use disorders and behavioral addictions. He completed his PhD in 2005 on the topic of cannabis use, its associated personality dimensions in the general population, and co-occurring mental health problems in vulnerable persons. In 2012, he received his postdoctoral lecture qualification for psychology with the specialization for treatment and diagnostic of substance use disorders at the University of Zurich, and was appointed associate professor in 2019. His current research focus is on internet interventions for the reduction of substance use and substance use disorders, as well as for the treatment of behavioral addictions. As such, he led, amongst others, the first low and middle income study among internet interventions in the field of substance use disorders, evaluating the effectiveness of the WHO-based self-help intervention Alcohol eHelp in Belarus, Brazil, India, and Mexico. He is a scientific expert in addiction research for the World Health Organization and the United Nations Office on Drug and Crime. Moreover, he's an appointed member to the Technical Advisory Group on the mental health impacts of COVID-19 in the WHO European region. The title of Dr. Schaub's keynote speech is Selge Program, Controlled Drinking and Depression Reduction with iCBT Implemented in a National Prevention Program. You may begin whenever you're ready, Dr. Schaub. Welcome.
Thank you very much for your kind and extensive introduction, Pam. And I want to thank you also, Michael, for this invitation to have today this keynote. And say good morning, good afternoon, and good evening to everyone who is online now. The next half hour we'll be presenting two of the most recent study. You will see that I also mentioned the online program we are using. And you will see it also later in my presentation. Then I have to thank to my team. So those things I'm going to present to you this evening. For me, it's evening. Is everything for me. It's also from my team here in Zurich. And there are programmers, psychologists, epidemiologists, and so on and so forth. And all the funding from these two studies this evening are from EU funding and from the Swiss Alcohol Research Fund. And I have no other conflicts of interest, so no money from IT companies or the like. Content is clear, a brief introduction, the background, then this effectiveness of Selge study, it says Selge in Estonia. And the second study I will present is the study of Take Care of You. This is a study that was conducted in German-speaking countries. And then we, of course, will have time for discussion and conclusion, approximately 10 minutes. I learned in the last year that it's important that we have some definitions of terms, because it's not a new field that I will be talking about, but there are some terms that it's important that we understand the same thing. The one which is issue that is used more and more is the term IMIS, standing for mobile-based intervention. This is the case since we learned that many interventions are not very good if they are only on mobiles or only apps for people with substance use disorder problems. But it's better if they can access it by all their devices. And so that's why we also use the term IMIS. Next one is adherence-focused guidance. This is about non-therapeutic guidance to increase frequent adherence problems that we, of course, particularly meet in people with substance use disorder problems. Another term you might be familiar with is guided self-help. This stands for internet-based self-help supported by an e-coach system. So these two studies I'm going to present are both based on e-coach systems and or professional online counseling or therapy. Yes. And the blended treatment, that is the next step. I just saw that there was also a workshop on that in the last half an hour. This means a suitable combination of face-to-face and online therapy so that the disadvantages of one format can be compensated for by the advantages for the other and vice versa. So it's really about the optimization of treatment. When you look at it from a technical point of view, if you have pure online self-help, you have the problem that the addiction specialist, on the one hand, really needs to look when a patient is coming one day to the clinic on his or her smartphone to see what really she or he was entering, what she or he is doing. So there is no direct access to a database. And what I will be presenting today is really about guided self-help. So from a technical point of view, you have a common database where there is access online on his or her online app or program. The addiction specialist can see by a documentation system what the participant, the patient, the client is doing actually in the app the whole time. So it's really about sharing a common database. What I'm not going to have time today for present or talk a lot is this blended treatment. So this is really the optimization of face-to-face versus with online treatment. And you see many of the newer approach are using this kind of toolboxes where really there can be a very tailored way from the addiction specialist saying, why don't you look at this and this questionnaire, this and this CBT module, and so on and so forth. So it's really about tailoring onto the individual patient. So what about effectiveness studies so far of internet and mobile-based interventions in the domain of alcohol? It's a bit an older study, meta-analysis from Helen Riepen, my colleague. And what you can see from the very beginning is that almost all studies had positive results in regard of the effectiveness for the intervention group compared to the control group. That's quite good, actually, in the substance use disorder field. If we look a little bit more in the detail, it's a bit more complicated. Helen Riepen found that in their previous meta-analysis from 2011, but also in the individual patient data meta-analysis from 2018, that extended self-help is more effective than one-time personalized feedback. And she found also that this guided format of self-help is better than, more effective than self-help alone when really looking at several studies and comparing by individual patient meta-analysis data. There are some older studies and meta-analysis, for instance, from Sally Rookie, showing that studies for controlled drinking show higher effects than those focusing on abstinence. One could have expected this from the practice or from the face-to-face treatment. And what is quite a new finding is that there are similar use reductions of about 5 standard units per week for harmful drinkers and heavy drinkers. So this means, and I was often told, particularly when I went to Germany, well, you are talking about the moderate drinkers, not the really heavy drinker we have in psychotherapy in the clinics and so on. But actually, heavy drinkers do also reduce 5 standard units a week, very similar to harmful drinkers on average, when we look at these studies performed so far up to 2018. the other hand, this means also that the heavy drinkers still drink a lot when they use from 35 or 50 standard units, only 5 standard units a week. And they are so far also urgently needed, actually, now in the COVID crisis worldwide. There are no studies on blended treatment. But of course, practitioners really are asking all the time, why don't you do this? Well, I'm actually starting to do it now. Regarding depression and alcohol use disorders, well, depression and harmful alcohol use are often two of the top five leading causes of years of life loss to disability, especially in high-income countries. This is based on WHO data. And these are quite some older studies, but perhaps there are things that you already know. So the co-occurrence of alcohol use disorder and depression is common, is associated with considerable adverse event, and so on and so forth. So actually, there are not so many new studies because this is a bit common knowledge that this is making it more difficult. But still, we wanted to ask, is it worthwhile to include depression symptom reduction approach in online alcohol reduction interventions? And if so, in which populations? So what about combination of treatment, so integrated? These are mainly the questions of the 2 studies I'm going to present today. So Selge means, or Selge means sober and clean in Estonian. That this website was in Estonian and in Russian, as 30% of the Estonian population is actually Russian speaking. Main research question was, what are the effects of an integrated alcohol and depression, cognitive behavioral therapy, internet and mobile-based intervention with a semi-automated e-coach system compared with an active personalized normative feedback control group in alcohol users recruited from the general population and not only by the general, but as part of a national prevention campaign. And you see for the study, the inclusion criteria was harmful or hazardous alcohol use at least, so audit score above 7. So why Estonia? You might ask yourself. Well, Estonia has the 3rd highest alcohol attributable mortality rate in EU. So basically they are drinking vodka, not only in the evenings. And only 2% of adult problem drinkers were receiving treatment. And this is a study really conducted in 2014. So really, really low treatment coverage. But on the other hand, IT solutions are very common and trend-setting in Estonia. There are for many years now electronic patient records for everyone in the population. And actually, we do not have it for many problems we have here in Switzerland, for instance. And actually, the Schaub program was invented in Estonia and not in the Silicon Valley. And there was this national alcohol prevention campaign, as you can see, in 6 years, but there were really no alcohol prevention or treatment services available online in Estonia. So there was really the possibility to introduce such a kind of online guided treatment within a national prevention campaign on the one hand, and there was no really co-occurring concurrence problems that we usually meet German-speaking cantons, where we have already many offers and programs, and you always have to compete with them. And of course, when you have quite an assessment at baseline, then people stop filling it out and switch to other treatments that most of them are not really tested for effectiveness. But of course, there are a lot of questions and answers there. So there is this Michael. As you can see in Estonia and in Russian, it has to be a man, the e-coach. And of course, there are some automated graphs for mood and drinking diaries. So when it comes to a model, and he will talk in every front of every model and ask people and says hello again, welcome to the next module. He will say yeah, today these are the contents of this and that module we are having now. And then he says, well, see you next week in the next module. And these are the contents translated for you now in English. So you see there are quite some modules. Some are based really for alcohol use disorder. Some are integrated modules, and some for the meeting your cognitive behavioral therapy for depression. While in the control group, they were receiving this web page. You see, it's not only an audit, it's looking good. And you can see there are also hints how to reduce alcohol drinking, information for loved ones, advice and help. And there was really, if you scored high, there was really access, and they were asking, where are you living? And there was really provision of face-to-face treatment next to you, also for those that scored higher than 7 in this audit. So it was really an active control group. Screening, brief intervention, and a bit of referral to treatment. We actually assess for eligibility, and here's the trial for around 880 participants, and you can see that some refused to participate and some not meeting inclusion criteria, so an audit below 7, and we finally could randomize 589. And what was really remarkable, we recruited these 508 within 3 months. So this is really an advantage if you really are embedded with an RCT in a national prevention campaign. You can see that we lost some, and I don't go into details. If you really want to see the details, please refer to the publications. What about the results? Well, this is audit change course. And what you can see is that in the intervention group, we had about reductions between baseline to follow-up of 7 points, while in the control group, which is screening, brief intervention, and bit referral, there were only 4 points. And you see this is quite good, and we have a coincidence of 0.49, which is equal to regarding secondary outcomes. You see that many and almost all of the secondary outcomes actually also better in the intervention group, so the change intervention versus the control group. You see the effect sizes were a bit lower, there's an audit, but also the drinking motives were up than the change control group, and also mental health actually was more reduced mental health problems than in the control group. So the discussion for this study is, this is really the first study comparing a minimal guided EMI with an active personalized normative dissemination control group. It's also the first study within a national alcohol prevention campaign that I know, where there was really no other offers within a country. The alcohol consumption reduction effects were consistent with the effect size reported in this individual patient data meta-analysis of EMI and Reaper, albeit the active control condition. So we really, most of the study in this Hell and Reaper analysis were control study like waiting list or assessment only control. So that's quite good. The depression reduction was compared to the active control group in a rather lower range, but as you might remember, this was not in exclusion, not having depression. So it was not an inclusion criteria. Not depressed persons recruited in this study. And now, I guess there will be about 6,000 now really that did the whole Selge program in the meanwhile, and you can see that already in 2020 there were over 3,000 by the end of 2020, so 1 year later when we finished study recruitment. So this brings me to the next study. Take care of you. And therefore I have to be a bit provide you a little bit more background about digital interventions for alcohol and depression. So we're really now focusing on both problems. There was a study on not online, but computer-based by Kay Lamping in Australia, reported on different populations. This was a treatment for an integrated treatment for alcohol, sometimes also cannabis included, and depression in a clinical sample. You see, there was quite nice, but there were also 3 groups. And finally, she could say that therapist delivered computer-based treatment was superior to computer-based treatment only. He is also from Australia, if I remember well. Integrated online treatment for adolescents. You see, this was unfortunately also quite a low sample size and also uneven distribution. Did not really find effects, only some small effects in the pre-post comparison. There was a very recent study from John Cunningham, some of you might know him, comparing mood gym versus mood gym plus a brief personalized feedback for alcohol reduction. And he found no between group differences regarding alcohol use and depression. And my guess is mood gym is one of the very first depression reduction intervention, and it's a bit outdated, I would say, honestly. So probably this was a bit the problem. So in the Take Care of You study, the main research question was, what effect has an integrated alcohol and depression versus an alcohol-only cognitive behavioral therapy, internet and mobile semi-automated e-coach system in at least not only alcohol misusers, but also at least moderately depressed alcohol users. So here we had really also CST, Center of Epidemiological Studies, depression scale score of above 10 and an audit higher than 7. And you see there are no upper limits. So we also have recruited really depressed ones with high alcohol use disorder identification. It was, this study was a 3-arm randomized controlled trial with pre-post measure, a first follow-up after 3 months after baseline, and a further follow-up 6 months after baseline assessment. This is how it looks like in the Austrian version. So there is explanation video, you can log in. It's adaptive also for smartphone and tablets. This time you see it in the German speaking or the Western part of Europe, it really needs to be a woman as in coach, which is quite interesting, and not a man like in Estonia. And there is Lena, and she's the e-coach. It looks very similar. As you can see, it's more or less the same program as this Selge program. However, what we had were 2 active groups. The first one was really integrated treatment for alcohol use disorder and depression. So saying yes, for instance, is really about behavioral activation. Sorrows and Problem is really CBT-based program integrated for alcohol reduction and reduction of depression symptoms. While in the second arm, you see, I'm switching here, there was really intervention focusing really only on alcohol. So nothing about depression, nothing about mood problems, and that could be affected to your alcohol problems and vice versa. Nothing of this. As it looks like, some slides. And here is the trial for already. You see, we needed, as we had these double conditions, really depression scoring and audit scoring higher. We need to really screen over 1,200 subjects. Excluded finally are almost 700 people. You see that there were some below 8 in the audit, some in the CST below. So it's really the general population. That's why we did not have really a clinical sample. And randomized in the 3 group is 689. Exactly. I don't go into details either here to save time. Please have a look at the details. One note is people were recruited from most Austria, some from Switzerland, and some from Germany. So, gender distribution, you see that we almost had equal gender in this at the beginning. I introduced as an intervention for the depression reduction and alcohol use reduction. The age on average was about 43 years. Of course, audit was quite high, on average 19.8, and as you might know, higher than 21 score on the audit is really suggestive of dependence. So it's not only occasional drinkers. County results. I will guide you through this slide. It's based on intention to treat analysis. Yes. So everyone was included in this analysis, no matter when they left the intervention or if they left the intervention. Meanwhile, it did not follow all the models. The green line is for internet, stands for internet as usual. This was the control group. As you see that they reduce also from on average about 40 drinks, standard drinks a week, to about 26 after 6 months, the final survey. Then the red line is the adherence focus guidance enhancement for this integrated intervention, so alcohol and depression. And you can see it's quite similar as the alcohol-only intervention. This was exactly what we were looking for, because the alcohol-only intervention was a very sophisticated, already studied and proven effective treatment. And the integrated one was really based on this one, the alcohol-only, but added some really integrated contents for depression reduction. And we also conducted some explorative studies, analysis to show if they were equal and based a priori effective effect size differences. And this actually turned to be out that we can't say it's more or less equal, this intervention. See, the effect size, the quantity, are quite low, for between group differences. While when we look at the alcohol use disorder identification test effects, this was the first secondary outcome, you see the effect sizes intention to treat for alcohol and depression were higher. So we had about a quantity of 0.5 for alcohol and depression intervention, the integrated about 0.7 for the alcohol-only intervention. What was surprising actually was the depression reduction. So based on this CSD score, similar, although we did not address this in the alcohol only, so the yellow line intervention. But you see it were in both groups reduced on about 0.5. So the discussion for this study, the alcohol use reduction effects were smaller than expected, but consistent with the effect sizes reported for previous research examining face-to-face treatment. So patient data meta-analysis on internet and mobile-based intervention for reducing alcohol use. You can see this HC is about 0.26 in first studies. The effects in the audit reduction were considerably higher than study, the first study I presented, but there, of course, we had an active control group and not the internet as usual waiting list control group. But it increased slightly in the longer term, especially in the alcohol-only group. The effects on depression symptom of depressive symptom reduction were similar to the DEAL project and slightly higher than the non-significant results in this recent meta-analysis. That might be interesting for those that are really interested in this integrated digital intervention. This was a meta-analysis published in 2021 by Schaub et al. My conclusions and also my take-home messages for you before we have, of course, some time for discussion. Guided self-help on the internet works relatively well for the reduction of alcohol use, as well as the treatment of alcohol use disorder symptoms and better than self-help alone. This is clear now. There are no studies on blended treatment, unfortunately, for the treatment of alcohol use disorders so far, and of course this is one of the next things we should do and invest our efforts. Both integrated alcohol and depression guided EMIS reduced alcohol use, audit and depression score. And of course, I would say further dissemination is recommended. We also completed now a study in Canada. It's called Take Care of Me, not Take Care of You, as we had in the German-speaking countries. However, the question, and this is also leading to our discussion, the question for which groups of persons integrated guided EMIS for alcohol and depression reduction is worthwhile, that needs further to be researched. There are some notes on the interventions. My presentation will be also, I will be sharing my presentation slide, of course. And for now.
Thank you very much, Dr. Schaub. That was really, really interesting work that you're doing. I was quite fascinated by your findings. There's a couple questions here that I will pose to you. So the first is thanking you for your presentation. And given that the Selge program focuses on alcohol use disorder, how could the current program translate to an e-health program for people with opioid use disorder?
Oh, that's a difficult question. Of course, we are also developing internet-based interventions for opioid use disorders. And at least adherence-focused guidance, in addition, as an add-on, for instance, to substitution treatment or other treatment of opioid disorders. And the other option would be, which we are actually now really developing, is blended treatment. So really having face-to-face, ideally combined with internet and mobile-based intervention. So with this kind of toolbox where the patient can answer some things, fill out some questionnaires, or just have some fun. This is also important, of course. So not only self-harm.
Thank you. Okay, there's a couple more questions here. Are there differences in engagement and outcomes for people who are in the pre-contemplative or contemplative stages of change versus people who are actively looking to change, reduce their alcohol use?
Oh, that's a difficult question. I'm not so happy with this distinction of pre-contemplation and contemplation. For me, it's always important that people start reducing or start stopping drinking or using drugs, or that's important. And sometimes there is only a quick decision, and this leads to happy outcomes in the end. So it's not always required, I think, this is really going to all these processes from pre-contemplation, contemplation, and acts, and so forth. Yes, we're a bit critical, and there are also other, for instance, Robert West, for many years ago, wrote quite an editorial on this distinction, and maybe you read this once, and this really opened a little bit my eyes. It was published in Addiction. It's saying, the title is putting the changes of stages of change model to a rest, things like approximately like this. But of course, we also had this kind of motivational interviewing contents as far as it is possible for the introduction. Specifically in the first module, we have this kind of pros and cons distinction, putting everything on the one hand and see what is more and what is less. And the main idea is that they really start to think about the drinking or the depression and how this could be interlinked, or what could be the reasons why they are drinking, how this is connected to mood problems or a very good mood also. I hope this answers a little bit your question.
Yes, these aren't easy questions to answer. All right, on to the next one. The research article, Taking Care of You, so published in 2021, can be a valuable addition to the general healthcare system, given that they're generally are very cost effective and can run automatically with minimal human support. What does minimum human support mean or look like in this case?
I did not go into too much details. That's a good question. Actually, we had trained master psychology students supervised by me, more or less, and for instance, they had the job to answer messages. So there was always the possibility to write to an e-coach, and they were answering to them. And the questions they were writing were mainly, is there anybody behind this e-coach? Oh, there's someone with a reply. So it was really more an interaction and not a therapeutic communication. And this was announced from the very beginning. And there were also some automated messages. So for instance, if people, but the very easy ones, if people the participants did not log in for a week, they received some reminder mail by the e-coach. Hey, hello, I noticed that you did not log in this week. Direct link, just go back to the intervention and fill out your consumption diary, for instance. But there are also some more complicated, really automated messages. For instance, we saw that you have in your pro and contra, pro and cons module filled out, that's drinking in the evening and saying no if you get it offered by a nice man, for instance, or a nice woman, could be a problem for you. So why don't you go to directly to module 7, where there is some important information for you really on this topic. So but these were automated, and most of the other ones, they were kind of waiting for messages and writing back if somebody asked. So that's what we are thinking of. So, and what's surprisingly perhaps that only about 8% of the participants that really went to this intervention, if I remember well, completed at least, really asked once a question. So this was quite cost effective. We are currently now analyzing the cost effectiveness of this intervention, and this will be published hopefully soon. Yes.
Thank you. Just another question here. It's where in the studies, so it's approaches housing. So there's studies, advocacy, and more from frontline workers where that address substance use, trauma, and mental health that indicate a housing first approach as the first step to addressing it. So I guess, the question, well, does that really fit into what you're talking about, or is it kind of on the periphery?
Actually, we are conducting a study now for trauma survivors. So with someone is jumping in front of the train, of course, could be a trauma. If someone is jumping out of the window and you know this person, and we have really similar approaches. So there are some emergency psychologists coming there, and for most of the people, they will some more or less by their own or by the beloved ones be helped out of this problem. But they will receive the option to face-to-face follow-ups and also an online intervention. And I think this model could be very well so kind of a combination of face-to-face. It's not really blended, but it's like of having some short contacts in the very beginning, offering additional help by internet. There will be some automated reminder emails or reminder calls, you can also imagine, by telephone. And this could already make a difference. So when you have this housing approach, I really much would recommend this approach more than this e-coach system. Yes, so there will be a kind of a housing team, the address. Yes.
That is perfect. You know, so thank you. We are at the end. There was one more comment, more agreeing that just that timing when you were talking about motivational interviewing and really how to address the timing. But anyways, I want to thank everybody for attending this session, and thank you for that really, really interesting keynote, Dr. Schaub. That officially concludes this session. Thank you, everyone.
Thank you very much, Pam, for all your work. Thank you.
You're welcome.
Bye-bye.
Goodbye.